Welcome to the inaugural edition of Nurse to Health. This is Dr. Robert Gluck. Nurse to Health is a program that is going to introduce you to the world of healthcare from the perspective of nurses and physician assistants and way beyond. This program is done in collaboration with the Hofstra School of Nursing and Physician Assistant Studies and Northwell. We thought we'd just introduce during this inaugural session ourselves, what we're all about. So I'm going to turn it over to my co-host, Kareem Nugdalla, and tell us about yourself, Kareem.
I am a professor here at Hofstra. I am the lead Pearls faculty member. I'm head of the first year of the NP program, so that's for the graduate nurses. In my average everyday life, I'm a father of 3, a husband. I also run a civic association out in Coram, so I do a lot of community service. In terms of my clinical practice as a nurse practitioner, I do cardiology at South Shore Hospital. I've been practicing there for many, many years. I had my education here at Hofstra, so well involved in the community here. And, I'm actually very excited for this, that we can actually do this, because there are a lot of topics from the nursing standpoint that don't really make it to the forefront. So, yeah, I'm excited to talk about this.
It's fair to say you're a pretty busy guy.
Listen, we're all working hard. We're trying to make something happen here, and it's tough, juggling everything, juggling your average everyday life, but with the hospital, with Hofstra, teaching responsibilities, it's tough, but look, we made time, so they say if there's a will, there's a way, so we're here.
Yeah, which is why we're together. The idea was there are these other podcasts out there. We wanted to bring a different, new, innovative, fresh, fun perspective, serious at times, but keeping it fun and real. You and I are different. I'm this MD. I'm not a nurse, right? The program's called Nurse to Health, but I'm faculty in the nursing school, but I'm a surgeon. Spent my career in the Northwell system as a surgeon. I'm this Jewish kid from Long Island, and you're not. You have a nursing background. Not only are you active presently clinically, but you trained in this program.
Absolutely.
We're going to try and bring, really different perspectives to this. We're going to have some really cool guests lined up.
Yes.
High impact national leaders from the Northwell system, from Hofstra. We're also planning to have a bunch of students on. So a lot of our students are not only students, they're presently actively working at just about every major institution on Long Island and in the New York City area.
For sure, even out of our health system, actually. Yes.
So why don't you talk about that? Because that's going to be a big part of this program. We're going to have students on here. We're going to be keeping it real.
Mm-hmm.
We're going to talk about the educational side. We'll have people from the C-suite in the boardroom. We'll have all of that. And we'll have, experts. But we're also going to have people in training. So, talk a little bit about what's going on with the Hofstra Northwell School. We'll get, we're going to get to physician assistant studies as well, but just, you know a lot about the nursing sides.
Initially the school started with a graduate program. That was the program that I was in, the inaugural class at least. It was new, it was innovative, and it was new and innovative because it was a type of program that was never really done before. If you think about it, it was Pearls. They implemented Pearls.
So let me interrupt you. Just nobody but you and me and a few other people in the school are going to know what the heck we're talking about. What Pearls? I know it stands for.
It's patient explorations and active reasoning and learning synthesis.
Wow, I'm impressed, man. You get extra points for actually know what that stands for. Most even the faculty has no idea.
It's a fancy term really for a flipped classroom approach.
Yeah, so go ahead. I interrupted you. Go ahead and speak about that.
That's what it is really. So, in a typical learning environment, you come in, you sit down, professor is lecturing in the front of the room, you call it a day. You leave, everyone is happy. In this way, you get a facilitator. So you get someone to kind of lead the pack in a way, right? But the facilitator actually doesn't really teach you anything. They just make sure that the process is moving in the right direction. And so the students really have to be the leaders, and they have to be their own professors, and they have to teach themselves, and they have to teach each other, and it's a reverse classroom. So they basically get a case, they learn about the case, they pick out learning objectives or things that they want to be looking up throughout the week. They research those things, and they come back a week later, and they report out on those things. If the case is like a heart attack case, for example, they may get learning objectives related to heart failure myocardial infarction, an arrhythmia like atrial fibrillation. They look those things up. They look up the pathophysiology, the pharmacology, all the medications, and then they come back and they discuss it. What we found was that flipped classroom approach really just consolidates the information in their brain. When they get out into the clinical arena, they're like rock stars. They're running circles around their peers. And it's something that I believe the med school had adopted first, and we kind of adapted it from them. Even with the residents from the med school, they're doing fantastic in the clinical arena. So all around, I just feel like within our health system, now we have all these classes that have graduated, my class, and there's how many classes now? 6, 7 classes. So you're seeing the fruits of that labor now. All of these new providers who are able to think on their feet, take care of patients, give excellent patient care is really amazing, So like I said, I was in the inaugural class. My wife was in the program, and I know there's so many people, registered nurses, they see the difference of our graduates versus other graduates, and they're like, wow, you know what? I really want to go to Hofstra because I see the quality that's coming out of Hofstra, and it's something to be proud of. I think it's really amazing stuff that we're doing here.
Yeah, so you're right. I did start at the med school, which is where I first came across it, because when I came here, we'll talk about how that happened, how sort of suddenly ended my career in surgery because of a near life-ending accident. But I ended up at the med school. That's where I first had exposure to pearls. And yeah, it's well validated through the med school. They've published the heck out of it, and it does work. I mean, it doesn't work with every cohort, and we could talk about the structure of the nursing school. I mean, there's a lot of moving parts to the nursing PA program. The official title is nursing physician assistant, but it also involves one of just a couple of dozen perfusion programs in the country.
Right.
Those are the guys who, if you have to go for open heart surgery, they're guys keep you alive for the next couple hours while you're on a heart-lung machine. We have a lot of moving parts at the nursing school. We tried pearls with the undergraduate cohort.
Yeah, it didn't work out so great for them, actually.
It didn't work out great because it's really, like you were saying, it's very user-dependent.
Right.
Meaning, it's got to be a team of somewhat mature students.
Right.
Who know how to work together.
I also feel like in order for pearls to work, you have to start with something. You have to at least have some sort of baseline. With the med students and the NP students, like the NP students were nurses already. The med students, they have a bachelor's degree.
So NP, just again, most people...
Nurse practitioner.
Nurse practitioner, right. There we go.
The nurse practitioners and the physician assistants, they have some background, at least some background medical. I mean, even to get accepted to the school, you have to have some job experience, right? For the medical students, it's a similar thing. Like, they have a bachelor's degree, they did sciences, they know some things. The nursing students, they're coming fresh out of high school. How can they make a learning objective about something when they don't even really know, So in that aspect, it's not that it didn't really work. It's just, it's not a good fit, If you think about like the shoe doesn't really fit there.
Yeah, 100%. Yeah, and you're absolutely right about the med school. Med school is, they do what they do, and they do it great. It's a top-ranked med school, even though they're relatively young. But yeah, those students, like you said, they're more mature. A lot of them are just more advanced just in general, but a lot of them have done, in addition to just regular academic stuff, they've done multiple gap years, they've had other experiences. Yeah, so it's a more homogeneous, mature population. It works for sure for the grad students. People come into it kind of skeptical, right?
Totally.
I know I did. People
I was
are like,
skeptical. Are you kidding me? Like, yeah.
It's like, what, you want me to teach myself, right? What am I paying for, right?
Totally. When I first got here, I remember sitting down. They had all the bigwigs in the room, some of them who will be on this program with us. And I remember hearing flipped classroom, you're going to be teaching yourself. And I'm like, what did I sign? I mean, it was like buyer's remorse on steroids. I was like, what did I sign up for? What am I getting myself into? And I said, you know what? Let me just take it one step at a time. And that's kind of the message that we give each other. Like, trust the process, right? We keep telling the students that trust the process, trust the process, trust the process. And it's funny because we just had a convocation with our graduating class. That line kept coming through, even in the student that they had give the speech. He said, trust the process. Kind of making a joke about it, right? So it's like, it's something that's funny, but like you really have to just kind of have blind faith and just buckle in and do what you have to do, So.
And by the way, since you mentioned the convocation, just because my wife might at some point be listening.
Uh-huh.
Yeah, you were there. Speaking about pearls, you handed me my pearls award,
I
right?
I did. Very
so,
well deserved. It's interesting because the students actually, they nominated you for that. It wasn't like a faculty thing. I mean, you're a fantastic guy. I love you. But it was the students who recognized that, right? So it's a big accomplishment.
Yeah, I try to stay humble, but since you're here, you actually handed me the award.
I did,
I want to mention that. So, look, we'll talk more about the program, but yeah, we're going to draw on all these experiences, what works, what doesn't work, what sort of works, going forward. So maybe I'll just talk a little bit about me, my background. But I got to tell 2 jokes because that'll sort of segue into talking about me because I spent most of my career as a surgeon. So I'm going to tell a nurse joke and a surgeon joke. So see if you know this one. How long does it take a nurse to change a light bulb? Do you know this one?
I don't know.
It's 30 seconds to change it and 30 minutes to chart it. Okay.
That's very accurate.
That's very accurate. So yeah, I mean, I wanted to mention that because we're going to be talking a lot about stereotypes.
True.
We're going to be underscoring a lot of them because a lot of them, are there for a reason, and we'll be breaking some of them down. But then there's the surgeon one. How many surgeons does it take to screw in a light bulb?
I'm not sure.
Just one. They stand there holding the bulb and let the world revolve around them. See? So, I mean, I'm a surgeon. I can get away with that. So, again, I'm a medical doctor. I'm an interloper at the nursing school at this point. I love it. My dad was a medical doctor, a non-surgeon. He was an internist, hematologist, oncologist. So I grew up, quite literally from the time I could just barely walk. We lived in an apartment in Queens, and, you opened the door from where we lived and opened up into his office. And my indoor playground was, playing with skeletons and whatever other instruments he had in there. And then, it was a different time and place. He would take me with him to the local, it was St. Joseph's Catholic Hospital. I know a lot of friends of mine who went to parochial Catholic school have a different, opinion about the nuns. They could be tough, but I mean, they were great. I was this little Jewish kid, and they couldn't have treated me better, man. I have a soft spot in my heart for nuns, but he took me around there. That's what I grew up. I went to nursing homes at the time. I'll cut past a lot of the biography. I ended up in surgery and spent, my whole career, which was 35 or so years, at LIJ, part of the Northwell system. Started out in general surgery, trauma, and then did a fellowship in upper extremity orthopedics and microsurgery out at Stony Brook. And then, was happily doing my thing. Until 2019, and I'm a lifelong cyclist, bicycles, used to do triathlons and all that stuff. I've ridden all over the world. Maybe we'll tell some stories, travel stories sometime. But anyhow, I was out with a couple of friends one nice weekend morning and went down really hard. Ended up with emergency surgery, lost a couple of units of blood, ended up taking me by ambulance over to St. Francis in Roslyn. Broke my femur, which is the thigh bone, and my hip, tore up my knee, my back, my neck, concussion, a lot of fun stuff. Ended up in therapy for over a year and basically couldn't keep operating for various reasons. Called up some friends of mine from LIJ, from the ER over there that I'd known for a long time. They were at the med school at that point and basically told them what was going on, said, hey, you have anything for me to do? Yeah. And they said, not offhand, but come on over and we'll find something for you to do. And that's what I did. That was 2019. That, eventually sort of opened doors to the nursing school, and that's where I ended up. Yeah, it's been great. It's been an adventure.
Oh, that's a crazy story. I didn't know that about you. That's heavy. You basically had the perspective of not only being the provider, but also being on the patient side, too.
Yeah, I could keep this show going for multiple segments just based on my medical history.
Wow.
Back in 2010, had open heart surgery, so now I'm teaching the perfusionists. Yeah, a bunch of other stuff. But I think that's good. I think you and I and other guests we're going to have on this program, we're going to take different perspectives, past, present, future. And we're going to be looking at healthcare providers, both as providers and on the receiving end. We'll probably have a segment maybe just on COVID. We're sort of almost maybe past COVID, but COVID really opened the world to the lifestyles and the contributions of nurses and nursing, no?
Absolutely.
And physician assistants.
Absolutely.
Part of that discussion was what? Mental health issues.
Yep.
People taking long shifts, under stress, life and death issues, and, burnout and all the rest of it. You want to maybe just sort of touch on that for a little bit?
Yeah, sure. I mean, we're definitely going to be touching on a lot of these different topics. I mean, obviously we want to talk about the school, but we do want to talk about sort of these harder topics that, might be a little bit difficult to talk about, almost up for debate in a way. There's the whole mental health aspect, even if it's not from a healthcare standpoint. Like, as with the Quorum Civic Association, I'm dealing with a lot of issues with homelessness and their mental health crisis, drug-related, substance abuse sort of things. We can talk about all those things. And even within just like the overall trajectory of healthcare in general, COVID changed a lot of things. People before were really getting their healthcare in urgent care settings. I think COVID almost accelerated things for more of a preventative thing. People were saying, hey, you know what? I got to be healthy, because when COVID came around, if you weren't in the greatest shape, COVID could really hit you hard, and it took a lot of people's lives because of the predicament that they were in. So I noticed a lot of people are trying to visit primary doctors and get care in that sort of way to, hey, how can I get more healthy so that way if I do get something, I can brush it off rather than deal with whatever. But in terms of healthcare for us, for the providers, for our students, for our future providers, there's been a little bit of a retraction and attrition from nursing. People haven't really wanted to go into nursing after they saw what happened in COVID because it was so rough on everybody. I definitely want to explore that a little bit too, because nursing is a fantastic profession to get into. Being a physician assistant is a fantastic profession as well. I think COVID was something that caught us off guard in a way, and I think we have a lot more experience now moving forward. So
it's interesting you mentioned that. So on the one hand, maybe because of what people saw with COVID, the hurdles, the hardships, people putting themselves at risk physically, mentally, right? So maybe there's that element of it for some people in choosing that career. But on the other hand, the nurses of today, right, are not the nurses of yesteryear, right? It's a whole different thing. And that is certainly a big issue right now, what people call scope of practice in terms of, what can nurses do? And most especially, what can nurse practitioners and physician assistants do?
Absolutely.
Maybe you want to talk about that a little bit.
Yeah, I mean, there's definitely been some scope creep in a way, and you have to discuss those things because there is a delineation of scope for a specific reason. And then what we saw after COVID is that some people were given certain privileges just out of necessity. Essentially, the entire hospital became ICU overnight. And how can you effectively take care of every single bed in the hospital being ICU overnight without saying to people, okay, we're going to competency you in X, Y, and Z, and you have to be able to do these things.
Right, they had no choice.
Exactly.
I mean, there's just saying necessity is the mother of invention. In this case, necessity was the mother of scope expansion, because it's like, hey, either that or we have dead patients.
They had to. They had no choice. It was a very surreal time. I'll tell you, like, I cover cardiology, but, I became critical care overnight. Now, I am acute care, so it does cover critical care. But I will tell you that, I've had people who were my attendings who were OBGYN. They had to become critical care. They took people out of retirement, So all of those things were happening. In terms of the physician assistants, in terms of the nurse practitioners, this idea that you are a provider, but you have to answer. It's like, no, like, hey, we need you to be able to make this decision and make it now, because these people need the care and they need it now. Not later. It's not going to wait for someone to give a final approval. You need to do what you have to do. And obviously the physician is there as well. Even the physicians, right? Hey, yes, I know that you typically do this, but now you have to do this, this, and this. And it has to be done now. And to a certain degree, that sort of mindset has kind of remained, I think.
For sure. I think once the ship has sailed or the toothpaste is out of the tube or whatever metaphor you want, I mean, you just can't get it back. You can't go back. Yeah. Can't walk back certain trends. And now this leads to, for sure, a tension, right, between people who are out there on the front lines, meaning medical doctors and nurse practitioners, and certainly at the leadership level. I mean, the AMA, right, because this is a state-by-state thing, right?
Yes, it is. But, scope of practice within New York State, they gave nurse practitioners full practice authority after COVID.
Right. So, yeah, we're going to talk about that because there's a lot of leadership within medicine's not particularly happy about that, right? And
Can I tell you from a nurse practitioner standpoint? Yeah. I understand where they're coming from with that. I understand their concerns. That's why I think that our program almost bridges that gap in a way, right? Because if you look at traditional nurse practitioner training, I see a lot of the arguments coming from the AMA is all about training. You know, a residency is so structured, it's over such a long period of time. Yes, the nurse practitioner training is only in 3 years, but if you look at our methodology of preparing these nurse practitioners, you are essentially making them independent thinkers, right? You're teaching them how to fish for the information. You're doing this case-based learning, problem-based learning. The whole Pearls pedagogy almost bridges that gap, right? It's not you just sit in a classroom and hear somebody speak and you take a test and you're done. No, even our exams, like if you think of our exams, they're not multiple choice exams. Right. You're given a clinical scenario and you need to write down a paragraph.
I just graded them, right?
I know, they take forever. But just imagine, right? So it's real clinical reasoning every step of the way.
Yeah, look, you could talk about this as well as anybody on the planet because you're course director, you're teaching them. So yeah, for sure. Listen, it's good to hear you say that. You know, people become ideologic on these things and, you know, entrenched in their viewpoints, and it's like becomes very tribal.
Yeah.
Hey, you know, screw it. We're going to do what we need to do when we're, you know, it becomes an ego thing.
Totally.
You know, everybody in healthcare, you know, just in life, but especially in healthcare, you got to stay humble, right? Otherwise, you're not doing anybody a favor, certainly not your patients. So it's good to hear you say that. I mean, yeah, we need all to stay humble and stay in our lanes to the degree that we can, or, you know, we're going to cause harm and, you know, we don't want to do that.
Right.
Then there's the other tension, you know, we mentioned at the beginning, this is in collaboration with the Hofstra Northwell School of Nursing and Physician Assistant Studies. I mean, I get asked the question all the time. So, you know, tell me about physician assistants. They're part of that advanced practice providers, right? That's the terminology now.
They
APPs, and talk about that tension.
I would say that there's more tension between nurse practitioners and physician assistants than between nurse practitioners and physicians. Right? I think that if I'm looking at the training, the methodology, a physician assistant at once they get their degree versus a nurse practitioner, a physician assistant almost has the same level of freedom as a regular registered nurse. Meaning, like a physician assistant, they graduate from school, they can go into anything. If they want to do ortho, they can do ortho. If they want to do cardiology, they can do it. If they want to do OBGYN, they can do whatever they want to do. But a nurse practitioner can't do that. Right?
Nor an MD. You know, you become like I was a, you know, orthopedic hand surgeon, and
like
that's what you do. You don't suddenly become a dermatologist
or a
OBGYN.
Exactly.
Yeah, keep going with that.
So as a nurse practitioner, you can do, like, for example, I'm adult gerontology acute care. So that means from age 18 plus, I can see those people. So anyone who's 17 and below, I can't take care of them, right? Because it's not within my scope of practice, and that's something that's designated by the state. My wife is FNP, or family nurse practitioner, right? So she can see up from birth all the way up to elderly. Well, she can see people in a hospital, but it can't be like ICU or those sort of things. It's more of like a consulting service for an outpatient office. So it's more primary care, outpatient focused. And they can see women, children, you know, those sort of things. Then there's psych mental health. So psych mental health sees people with mental health issues, right? It's very simple. So there's this sort of delineation, like just because you're a nurse practitioner doesn't mean you can just go out there and practice and do whatever. And that's a safeguard in and of itself. Whereas a physician assistant, again, like they can just really, I mean, I've literally seen it. I've seen people who were, you know, medicine in a doctor's office, physician assistant, and then coming in the hospital working in orthopedic surgery. I've just seen those things. They have that ability to be flexible. And it's nice in a way because think about it. Let's say you want to move to another state somewhere. You can just move to another state and start practicing and do whatever. But a nurse practitioner is not like that. In New York State, it's very nice to practice in New York State. But if you wanted to go to like North Dakota or South Dakota where it's more restricted practice, you're not going to have the same level of autonomy.
Yeah, now just to be clear, we are going to have physician assistant leadership as guests. We've already have them lined up, so we'll be getting that perspective. But I think that's a pretty good introduction to it. Yeah, so how closely do you in your everyday practice work with physician assistants? Like what sort of interactions?
All the time. I mean, there's physician assistants that work with me in my own unit in cardiology, and I have physician assistants in other things, cardiothoracic. I mean, they're in every single service line within the hospital. Cardiothoracic surgery, I work with them, orthopedic surgery, medical ICU, surgical ICU, interventional cardiology, electrophysiology. I mean, you name it, they're there. Northwell kind of has this idea. They've coined the term called advanced care provider, or ACP. Right. So they don't really delineate the difference between a nurse practitioner and a physician assistant. A nurse practitioner, after a certain number of hours as per New York State, I think it's 3,600 hours. As long as you practice 3,600 hours with a collaborating physician, after that point in time, you're an independent provider. And an independent provider doesn't mean you can just go off and willy-nilly and do whatever. It just means that you are independently responsible.
This is specifically for nurse practitioners.
Specifically.
Right? Not
Physician assistants don't get
they need
that.
to be supervised.
Yeah.
Maybe that's not always happening, 100%, but that's a topic for another discussion.
If I had to think of a downside to a physician assistant, it's the fact that they have to take their board certification every 10 years. I think physicians have to do the same thing.
Yeah.
You have to retake the boards every 10 years. A nurse practitioner doesn't have to do that.
Oh, interesting.
A nurse practitioner has to go back and get RNFA, or a registered nurse first assist. So you need a separate certificate in order to go assist in the operating room. Physician assistant doesn't need that. Their coursework actually covers that sort of stuff. Ours doesn't.
Right. Interesting. Northwell, a lot of it's teaching programs, so we're training residents. Mm-hmm. Residents aren't always available, and you need another pair of hands, so we'd have physician assistants. They get highly trained in certain areas, like they're doing orthopedics.
Sure.
They're going to know not just the procedures, because hopefully the surgeon knows the anatomy and the actual procedure, but the technology is always changing. The systems, the devices, they keep up very well with that. And so you really collaborate well on that with physician assistants. Somebody just recently showed me some Bureau of Labor Statistics stats projecting forward like 5-10 years in terms of job volumes. Mm-hmm. And for physician assistant, nurse practitioners, it's like it was at least 20, 30, maybe 40%.
Oh, I can imagine.
Growth.
Totally.
So I just have to give a personal insight. So I have 3 kids, and my oldest, my son, was thinking about career in healthcare. Mm-hmm. It's in the family. I mentioned there's me. My dad was a doctor. My wife, both her parents were doctors. So he was naturally thinking about that. And I was like, hey, I loved my career as a physician, as a surgeon. I can't say every minute of it because I didn't like the paperwork, but taking care of actually being a doctor, taking care of patients, being in and out of the OR in my office, that was great. I told him, listen, by the time you get out, and we're talking about a dozen or so years, okay, between college, 4 years, let's say, 4 years of med school, 5+ years maybe of residency, then fellowship, maybe throw in a research year or two. You add that up, you're talking about a lot of years. I told him, hey, listen, if you really love it, go for it, but do your due diligence. Don't just take my opinion on it. Go talk to a lot of people, do your research, because when you get out, things are going to be not what they are right now. It's going to be a different world.
Right.
So the training for medical doctors is crazy.
Yeah, the physician obviously has, in terms of length of training, a lot more years of training. You guys have a residency, and a lot of you guys go for fellowships. There is no comparison. And we do have fellowships, but it's not like a requirement. Like for you guys, like for example, in cardiology, when I have a new physician who's coming, it's not just, I'm done with my med school. And no, it's a fellow. And there's training that has to go with that. I see the fellows, like they're covering overnights. They're doing things like it's not like they don't have free time. A nurse practitioner, we do have fellowships, but it's emerging, right? I think there's been a lot more focus on revamping the nurse practitioners' coursework, training, these sort of things. Pearls is one of them. I think it started years ago when I was in the inaugural class. That's kind of when the health system invested a lot of time, energy, and effort. Dean Gallo, for example, Mike Dowling, they were focused on those things. It's been expanding ever since, right? So now we have... and maybe we can get him to come on. Andrew Rojan, Dr. Rojan, who's doing the fellowship. Maybe he can come on and talk about those things as well. The NP's training is starting to become specialized in a way. But I will tell you, there's a couple of things that physicians get that nurse practitioners don't get. For example, like radiology certifications. Like to be board certified to read an echocardiogram. Like I don't see any effort being put in that trajectory for those sort of training. So what I'm starting to find, at least within the hospital, is the physicians will still see the patients, right? But the nurse practitioners basically are responsible for a majority of the care, and the physician is there for oversight because the physician is focusing more on procedures and interpreting whatever radiographic imaging that's being done. So if an echocardiogram was done, they are spending a majority of their time reading these echocardiograms, reading the EKGs, reading x-rays, CAT scans, scheduling procedures, doing those sort of things, right? The physician doesn't have the option of saying, I'm only going to work in the hospital. It's like, no, they work in the hospital, then they work in the office, then they work here, then they work there. So they're covering multiple aspects. It's almost like if you have a business, the CEO is overseeing everything, but then you have the second level beneath them that are specialized in certain different things to help run the business, right? So that's what I'm starting to see.
Yeah,
right?
for sure. Listen, I mean, it's crazy. And the question becomes, at the end of the day, is it overkill in terms of outcomes, especially when you're talking about an integrated healthcare system? Can you achieve the same outcomes? And look, we don't want to complicate things too much, but, we could throw AI into the mix and, make life really interesting. We'll certainly have some segments on that. So the end of the day is, how do we achieve the same outcome? All right, listen, so this has been great. We're going to sort of wrap things up now. Just to get back, I think we mentioned it, but just, to sort of put an exclamation point on nurse to health, that's sort of a double entendre sort of phrase. Nurse to health is sort of nurturing and supporting people in terms of maintaining their health and helping them back when they're sick and injured. So, we're certainly going to try and achieve that. That's our goal here. I'll give you the last word, and then we'll say goodbye until next time.
This has been Nurse to Health. We appreciate you listening in. Again, my name is Kareem Nugdalla. If you want to reach me, my email is Kareem, Kareem, .Nugdalla, Nugdalla, at Hofstra.edu. And I'm here with
Dr. Bob Gluck. My email address at Hofstra is Robert, Gluck, Gluck, at Hofstra.edu. And this has been the inaugural edition of Nurse to Health from the studios at WRHU Hofstra with the support of our wonderful engineer, John Mullen. Until next time, stay well.